Hello, and welcome to the Duke Cardiology Conference. I'm Sunil V, Assistant Professor of Medicine here at Duke University Medical Center. Today's program is titled Cardiovascular Prevention in the Asymptomatic Diabetic Patient. And my distinguished guest is Dr. Michael Blazing, Associate Professor of Medicine at the Duke Heart Center here in Durham, North Carolina. Mike, thanks for joining us.
Thank you for having me, Sunil.
So, Mike, we're doing a series of programs around a complex patient because these patients come into contact with multiple subspecialties during the course of their care. So for the sake of discussion, we have a 72-year-old diabetic patient who's been admitted to the hospital with acute coronary syndrome. She undergoes invasive risk stratification, ultimately undergoes stenting. And the question that she asks on the day of her discharge is, what could I have done to prevent this from happening? Now, I think we recognize that the diabetic patient is a high-risk substrate. But what can you tell us about primary prevention in the diabetic patient?
So I think what the patient needs to realize and what clinicians and providers need to realize is that the diabetic patient is a patient who essentially already has disease, or is at huge risk for disease is the big key. Now, the way I look at diabetes and cardiovascular disease is all of our data to date doesn't say that diabetes causes coronary disease. To me, what it does is sensitize individuals to the environmental factors that contribute to disease in a Western society. If you have diabetes or prediabetes metabolic syndrome, what that does is that makes you more likely to develop plaque. It also makes you more likely to rupture plaque, because I think it works on the two new tenets of atherosclerosis, and that is plaque formation and plaque stability. Mm-hmm. Okay, and I think that's what we need to talk about today.
Great. Show us what you have.
Okay. Let me just kind of go over first what we're going to talk about a little bit, and I think the key number one thing is to communicate exactly what I just told you to the patient, that they are sensitized to developing this disease. They need to be more vigilant than the average individual. It's hard for the patients to do this because they already feel put upon because you or they have to do more with regards to managing their diet. They have more medicines for their diabetes and their sugar control. Now I'm making them take more medicines for their cardiovascular system as well. So you have to be able to couch that right to start with. Then I'm going to talk a little bit about assessing the risk, what the approach should be to prevention, and then kind of summarize. So what's the real problem? If you look at diabetics over time, over 65% of them at some point in time will develop some sort of cardiovascular problem. Most of the death in diabetes is due to cardiovascular disease. So endocrinologists hate me for this, but what I like to say is that diabetes is simply a great cardiovascular risk marker. Okay, it is a vascular disease with sugar as a marker. Treating the sugar has been well shown to prevent small vessel disease, not highly correlated yet with preventing macrovascular disease. Again, I think the reason is because the process of diabetes itself, even before you get the positive sugar as a marker, really sensitizes your vessels to developing plaque and making plaque unstable.
So by microvascular disease, you're talking about retinopathy, nephropathy. The data are pretty solid there for glycemic control. And macrovascular.
And neuropathy and small vessel disease in the feet. Yes.
And so macrovascular, you're talking about vascular events, strokes, MIs.
Strokes and MIs.
And
right.
amputations, perhaps.
Correct. Okay. Exactly right. And so all the amputations, you have to be a little careful because the amputations often come from small vessel disease, don't feel, and then the bigger problem there. But I would agree otherwise 100%. Mm-hmm. Absolutely. Okay. And then the other problem, along with developing more disease, is you die younger than you should when you have diabetes. And one of the things patients always, they'll come into my clinic, and I have an older patient population clinic, as do most cardiovascular providers. I tell them my goal is to get them to 96, okay, and to get them well to 96. And they kind of like that goal for the most part. And to get them there, if they're diabetic, you really have to work hard. So exactly what the cause of this is, I don't know. If I could figure out, I'd be richer than Gates. It would be very nice, okay? But I think everybody's working very hard on what it will be. The treatment, at least the gross big treatments that we have right now, we know quite well. Manage the blood pressure, manage the cholesterol, use medications that are proven to make those numbers work, okay? And then go forward. And what I mean by that is we have a number of fantastic studies in hypertensive patients, a number of very good studies in diabetic patients using appropriate medications to lower the numbers to make things better. cutting someone's risk to lower their blood pressure, okay, will get you to the number. It probably isn't going to get the outcome you want. And so I try not to use medications that haven't been proven in the situation that we're talking about.
So you're talking about the difference between surrogate outcomes and clinical outcomes.
Absolutely, and I think in hypertensive management, you need to try and apply as much clinical outcome as you can rather than surrogate outcome, because surrogate outcome with a number, I can give people minoxidil and clonidine and make them all very normotensive. I'll make them miserable, but I'll make their numbers perfect. And where I see, unfortunately, regulation going is they're going to treat by the number, both for LDL and for hypertension. Okay, but we have to be a lot smarter than just paying attention to the number, because I think otherwise we're going to start hurting people. And I think we'll talk a little bit about ACCORD and how that might play into that as well. Okay, so clearly, recent trials also, and especially ACCORD, has brought this up, because in ACCORD, when you more aggressively treated glucose, you actually had worse outcomes. Now, there's some problems with this study in that other similar parallel studies done in Europe didn't have the same finding, but I think it is a good lesson that treating the number, especially if we don't know exactly how it is exactly we are treating the number with medications, pharmacologic approach, isn't going to work. The number that will always work for treatment is diet. Get the right diet, and people are going to do fine. Be diabetic, don't eat any sugar, very restricted carbohydrate diet, good weight loss, good weight control. You can control most people who don't have insulin insufficiency. You can treat most of those people quite well. It's just hard work, and hard work is hard to get people to follow. I think the biggest thing, again, the reason is, as I talk about this, is I like to think of diabetes as sensitizing people. Working on the numbers and working on the sensitization is key for the prevention, okay? And realizing that if you're more sensitive, it means you need to take a more aggressive approach towards prevention. And that aggressive approach is blood pressure management with the right drugs that have been shown to improve things, ACE inhibitors, perhaps amlodipine, looking at the ASCOT study that has come out, ACE inhibitors and amlodipine together, judicious use of beta blockade, careful use of beta blockade alone, because of its metabolic derangements and its imperfect control of central hypertension, okay, is the way I would put it, especially in the diabetic. So let me just talk about that for 1 second, because I think it is important, because people are so focused on beta blockers. Think about a beta blocker and think about it like this. If I have a very good heart and I'm a diabetic, and I've been a diabetic for a while and I've not had perfect blood pressure control, then what I'm going to have is somewhat thickened and somewhat stiff vessels. So I've turned my nice rubber tubes into steel pipes. Okay, and I have still a very good pump. So if I take a very good pump and push a fixed volume into a fixed system, I'm going to get a higher blood pressure than if I have a system that gives. Okay, that's the way I like to explain it to my patients. Now, take a beta blocker, slow my heart rate down more. We know from physiology, of course, that what that's going to do is increase contractility, which is going to actually increase the force of contraction. Increase the force of contraction into yet a still very fixed output system, and the systolic blood pressure goes up. That puts a huge amount of strain on the small vessels in the head that come off the big vessels in the head, which is the imperfect way God made us, okay? And hence leads to a lot of small vessel disease in the head. Maybe increases cognition issues over time, but definitely increases stroke over time. I think it's why beta blockers have half the efficacy of other antihypertensives in stroke prevention. It's why I'm very careful, even as a cardiologist, not to try and push beta blockade too far in these patients.
So tell us a little bit then about your antihypertensive, or maybe we're going to get to this, the antihypertensive approach in terms of pharmacology. What are your first-line agents?
So let me talk a little bit first about what I see the pathophysiology is to try and get at that, and then I'll talk to you about how I try and treat things, okay? So this series of cartoons that I've come up with really kind of gets a little bit at how I envision atherosclerosis and hypertension changes really occurring within anybody, but the diabetics especially. So what is it? So the way I like to talk about patients with it is a blister and a callus, okay? And I like to be able to communicate to my patients in words and images that they'll understand, because I think it makes them then manage their disease rather than me kind of talking over them. So I tell them that what happens with hypercholesterolemia and hypertension is you start to form blisters. And then those blisters, if you do well with treatment, get repaired and turn into calluses. And once they're callous, just like in your hand, you don't need to worry about it. If the blister stays, that's where you're in trouble because, as you know very well as an interventional cardiologist, most MI occurs because the blister ruptures, blood sticks, and a small plaque goes to a sudden obstruction, and that's the heart attack. So if we could just turn, number one, prevent the blisters from being made, and number two, any blisters that are there, get them to be turned into calluses, we'd be much better off. The way I then describe what goes on to them if they have diabetes is their endothelium, which is the protective lining that they have, shown here in blue, above the dark blue. So the Carolina blue above the Duke blue, I guess, okay, is that the diabetes affects the ability of that lining cell to actually prevent the infiltration of lipid and other substances yet to be completely discovered that then lead to plaque formation, okay? And as you can see here, what that then elicits as these things come in, the lipids, is a inflammatory response from macrophages, okay? That inflammatory response, if it becomes too vigorous, leads to more and different cells coming in, such as T cells. Macrophages being overwhelmed, they release substances which then lead to very poor fibrosis, very poor callus formation, and a very kind of what I like to call perilous plaque, okay? Ideally, if you're giving the right medications, what happens instead is you form a nice thick layer on top, okay, the callus. You actually deactivate the lipid pool underneath, and you actually inactivate inflammation at the side of the plaque. The result is a nice stable plaque. Maybe there's a lump, but if there's a little lump, it's not a big deal, okay? So the key question is how do you get there? I think this slide by Bruzzella gets at a lot of how you get there, but you take one look at it and you say, oh my God, because it's just too complex, okay? Put down simply, I think the way you get at it is you treat the hypertension, you treat the hyperlipidemia, you become comfortable with an approach to doing both, okay? And then when your level of expertise becomes exceeded, that's when you need to refer to the next level. I think that's the way you really need to do it. And the key for each physician, whether they be a primary care physician, a more primary cardiologist, or a tertiary center cardiologist, I think the key is to become familiar with what your role is, familiar with what the basics are of treatment, and understanding when the time is to move to the next step. Mm-hmm. Okay? So how do I do it? So what I try and do first is figure out the individual's risk, and I try and match their treatment to that risk. Okay? All right? I think an accurate history is the key with this. Okay? I think you want to make sure that when you're taking the initial history, especially in some of our older individuals, you're doing so with an eye towards, are you cutting back on what you're doing? Are you actually asymptomatic because you don't do anything now? Mm-hmm. And I don't know about you, but I see this all the time in my clinic. I'll see the new patient who's 70 years old. Their daughter or brother or somebody has sent them to come in. And you start talking to them, and they say, well, what did you do a year ago? I used to travel all the time. What do you do now? Nothing. Why? Oh, because. Okay, and the because is often because they've had symptoms but don't want to recognize them or don't want to admit to them. Yeah. Okay, and I think getting people to really, what happens when you walk up a flight of stairs? Mm-hmm. Why do you not walk up the flight of stairs if you don't? And not allowing orthopedic and or other issues to get in the way of trying to assess what's going on with them, backing off to prevent symptoms, I think is key. Okay, and then figuring out who's moderate risk and who's high risk and who's very high risk are the keys, okay? And then understanding that, you know, risk assessment, as cardiologists, we often say, okay, fine, we'll just stress test them. The problem with stress tests is there's a lot of false positives, there's some false negatives, and the key question I think you have to ask before you go into the test is, if it's positive, what am I going to do? If it's negative, what am I going to do? And what's the message of this test and the purpose of the test in the first place? Personally, when I order a stress test, my most important thing is I want to know how far you can walk, because that tells me more than anything else about what the patient's prognosis is going to be and what I need to do. I think our current studies of medical management in coronary disease clearly show that if you can participate in cardiac rehab, if you can take your medications and you're cognitive enough to do so, you can do as well as anybody who's intervened upon, just about. Just about. The exceptions may be left main and very proximal LA disease or an acute coronary syndrome patient. But the rest of the patients we're talking about, I think the COURAGE study went a long way in really proving that point. But the key in the COURAGE study was we knew everybody's anatomy and we knew everybody's ability to do something. I think if you don't get a good feel for that, for what they can do, I mow the lawn, I do things like that, or you don't get a good objective feel for that with a stress test, you need that stress test, but with an idea of measuring objectively where you're going, with an idea of then, only pursuing invasive therapy if you think the risk is high enough to warrant prevention. Because we know stenting people doesn't prolong their life and doesn't prevent MI.
So let me ask you about a specific patient scenario that comes up fairly often, which is a patient who has a normal stress test, but they weren't able to reach their target heart rate. Is that someone that you say has been deconditioned? You work on, primary prevention kind of strategies first?
So a lot depends on how far they can go before they don't reach their target heart rate. So if I get somebody who can't reach their target heart rate because they went 10 minutes, I'm very unconcerned about that patient, quite clearly. Okay. If I get somebody who can't reach their target heart rate and stops at 2.5 minutes, I think all of the literature we've looked at with regards to long-term evaluation of patients, women and men, has shown that if you have poor fitness, you die early. Okay, and then the question is if you did the walk, say you went 3 minutes on a stress test, which is barely walking down the street. If you stopped because you were fatigued, not short of breath, no pressure, and being very careful with regards to those two things, no change in your EKG, I think it would be reasonable at that point in time to try and put somebody through an exercise rather than to pursue a cath, provided you're clinically satisfied, and you have to be very satisfied, that this is all deconditioning and not being limited by a very high EDP, okay, severe coronary disease. And that's what I think you have to differentiate. And how do you differentiate those two things? Did you get short of breath? Okay. Was the fatigue simply in your legs or was it in your chest? Where is it that you really made you stop?
So
why
this is
I
an
don't
area,
like pharmacologic tests.
So this is an area where really interacting with the patient is very, very helpful.
Absolutely important. Absolutely important. You know what the conditions of the stress test were, how they felt on the stress test, and you talk to them before they go into the stress test knowing that you've got to give it your all and really push. And if you don't, we're not going to get the answer you want. Because the submaximal test otherwise isn't going to tell us anything. So, and then I think once you get the testing and once you get your risk assessment, what you want to do is match your treatment with the costs of treatment. And the costs of treatment aren't just financial nowadays. And I think Walmart and Target and all the other places with the $4 medicines have really helped with the financial cost of treatment because you have so many options now. The true cost of treatment today, to me, is the cost of the side effects of the drugs. Okay, both well talked about and not well talked about, and or put over. Oh, you'll be fine on this beta blocker. I think what we got to do is put every cardiologist or every medical student on a beta blocker for a month and give them a good idea of exactly what it feels. That isn't fun. Okay, for the most part. Some people can tolerate it well, many people don't. And if they don't, you have to listen, and if you don't, you'll lose your credibility. Sometimes you have to tell them, I have no other options, and if you don't want to take it, that's fine, but realize that you're at increased risk if you don't. Okay? And so communication is the key with those things. I think you also have to, in today's world, make sure that you can counter that all-being, all-knowing Mr. Google, okay, where someone comes up and says, I have itchy teeth. So they Google itchy teeth. You can't have itchy teeth, of course, as you know. Yeah. Okay, as one of our mentors has told us, right? Okay. They Google itchy teeth and they come up with the medicine that causes itchy teeth and they won't take it then. I think the misinformation you have to set when you give people new drugs, you have to tell them what to expect. You have to be very honest about the side effects. Tell them that it may make them feel poorly, but they have to try it and see what happens. Be flexible with being able to move it and keep them away from the disinformation. Because the disinformation just kills you. one of my favorite things with doing that, and we'll go over that in just a second when we talk about statins, is to put some risks into kind of everyday life occurrences, and I think that really helps with people, and then the light kind of goes on with them. Let's first talk about DIAD. This is an interesting study just recently published, okay? And what they did here in a diabetic population is they looked at the efficacy of just stress testing these people overall. If you take everybody's diabetic and you stress test them versus people who aren't diabetic and don't stress test them, what are you going to find out with? Okay, what you found is that the stress tests were not actually useful in helping to manage the population over time. You found that markedly positive stress testing was associated with higher risk, okay, but the positive predicted value was low. So if you have somebody who's really positive, they're not going to possibly do well, but the likelihood of finding somebody who's really positive is really low. Mm-hmm. Okay, so the utility just isn't there if you just use the test as your initial screening tool rather than your brain. Okay, and I think that's a key finding from this. It's just stress testing still isn't good enough to do this.
And interesting, that's they use pharmacologic stress.
That's correct, and it's something I would have never used.
Yeah.
It makes it a nice study in that it's very clean because everybody gets the same kind of study between different areas. It's a horrible study in that I think the most important thing is how far you go on the treadmill, not anything else, because it tells you more about their risk than anything else like we talked about earlier. I think the other key study here with regards to revascularization is Berry 2D that found no survival benefit with regards to revascularization versus medical therapy. Okay. There was a reduction in MI, only those who underwent bypass surgery, okay? And most of the benefit was in those receiving insulin and not those on oral therapy still. And I think it just shows probably most of the benefit was in those with the most advanced disease, and both diabetic-wise and cardiovascular-wise, for that reason. So how is it that I apply the goals? And this is what I think the meat of this talk really is. And I think that ACCORD has gone a long way here in showing, again, if there's a conundrum we have in that if I'm writing guidelines and I want a whole bunch of people to understand the guidelines, numbers are really easy to use and data's difficult because the data becomes jumbled very quickly. However, if the numbers don't correlate well with what I want to do, I'm in trouble as a guideline writer. And so consequently, that's what we're finding in hypertension. I don't think we'll find it in lipid management, fortunately, but I think in hypertension we're definitely going to find that. And that is that if you just go by a numbers approach, everybody has to have this number to do well. Lower isn't going to be better. And I think that this is going to be the first of many studies that are going to show that as well. I know that the NIH is currently taking on a big program grant project looking at another lower is better in a general population rather than diabetic population. Actually, interestingly enough, and to their credit, looking at harm as well as benefit in this, looking at 120 to 140 for harm versus benefit. And again, the interesting thing in ACCORD was that we didn't find benefit getting people down lower to 120 versus 140. People can argue 130, 140, 120. I think the idea is, though, that too low isn't too good. Okay? And a lot of that has to do with the fact that all of this is essential hypertension, which means essentially I have no idea why I'm giving anybody these medicines, right? Because I have no idea what's wrong with their blood pressure in the first place. If we had a better idea of which of the 9 homeostatic mechanisms was out of whack in somebody, I think we'd do a lot better with lower is better. Okay. Hyperlipidemia, also very numbers driven by guidelines. Okay. So far, so good because the drugs have been so safe that we can get people down very low without a problem. The more you push, the more likely you are to have the side effects. What is the likelihood of having the side effects? I think you really need to put this into perspective. So first, what's the benefit? In an asymptomatic population, 10 milligrams of atorvastatin versus placebo, 37% reduction in MI. Okay, 37% reduction in first cardiovascular event. No reduction in death in this trial, but that's because it was stopped early. Okay. All right. I think had you carried this trial out, you'd have seen a reduction in death as well. I'm almost convinced of that. It wasn't ethical to do that. Okay. So I think everybody who's diabetic needs it, but I think the key with hyperlipidemia is knowing how to talk about the risk and to apply the medication appropriately. And what I typically try and do is understand how much LDL reduction you can get when you give a certain amount of statin. And shown here is how you can get 33% reduction. And as I like to say to the residents we teach, even a cardiologist can do 33% in their head. Most of them, not all of them. Okay? And by applying a dose like this, you can get 33% reduction. Every time you double it, you get 6% more reduction. Okay? So you can pretty much guess where you're going to get people to start with. And what you want to do is shoot for 100 or shoot for 70 with the diabetic. 100 for the diabetic who doesn't have disease, 70 for the diabetic who has known disease already. And then what's the risk of a statin? Okay? Two key things have helped me more than anything else in the risk. One, the likelihood of dying from a statin, you're 4 times more likely to be hit by lightning in the state of North Carolina. Okay? And that's a 1 in 250,000 in the state of North Carolina. Okay? And it's less than 1 in a million who die from a statin. The second is that the aspirin that everybody will take without hesitancy is 500 times more dangerous than the statin, at least, with regards to mortality. And morbidity, it's on the order of 5,000 times probably safer. Aspirin today, if you tried to get approved, would cost $6 a pill and have to have a special provision and 14 black box warnings because it would just never work.
Yeah.
Okay. Yet everyone will walk into your office and say, I have no problems taking my aspirin.
What's the most common complaint that you get about statins? Is it the soreness, the muscle
Most
aches?
common complaint is the soreness and then the worry about the liver.
Yeah.
So the worry about the liver you need to throw away right away, in that nobody has ever had liver transplantation or liver failure from statin alone in 100 million prescriptions. Okay? It just doesn't happen. It irritates the liver. You stop it. It goes away. You do not need to worry about it. And in fact, in some people who have ongoing liver disease, it actually helps rather than hinders, because fats actually make the liver disease worse than the statins do. With regards to the myopathy, myalgia, somewhere between 5 and 10% of all patients who come in will develop myopathy. Okay, mostly myalgia, just muscle pain. Okay, of that, say 10%, of 1 out of 10 people. So I'm going to take 1,000 people. Okay, that would be 100 of those 1,000 people. If I switch the statins and try around, of the 100 people out of the 1,000 that couldn't originally take it, 75 out of those 100 you can get to take some statin. 25 you won't. So about 2% of individuals won't be able to take a statin at all. Those people, then you have to try diet, exercise, and some of the other drugs, niacin, a fibrate, or a bile acid binding resin. Okay, but again, that's going to be the vast minority of patients. There are a number of drugs in the pipeline coming down that may much better treat cholesterol down the road for that group of people, and we're looking forward to those drugs. Inflammation, that's the newest thing coming up. What do you do about treating inflammation? Remember, I told you the 2 key tenets now are plaque formation and plaque stability. The best marker we have for plaque stability right now is generally inflammation through hsCRP. If you have high inflammation, the stability of your plaques is less likely there than if you have low inflammation. The only drug we know consistently that lowers hsCRP and has a benefit are statins. I think the Jupiter trial went a long way in showing that, without a doubt. Do I think it's going to be a marker in the future? Yes. Do I think it's there for prime time? Not quite yet. Okay. I do think the Jupiter study findings are quite impressive. The biggest problem I have is very few events in every arm. Okay. I would like to see other trials like it validated in somewhat other populations before I say it is as solid as the LDL hypothesis is. I think it's quite firm, however. Okay, I think hsCRP is where LDL was at the end of 4S. Very well established, but not a gold standard. Okay. Aspirin, just talked about it. Aspirin is actually going down and down and down as a preventive agent. There's a big question, as you know, with regards to the efficacy of aspirin in diabetics now even. And why is that? I think the reason for that is that when you look at the data for aspirin, it came about before we did any medical therapy, and aspirin alone is a great drug. Start treating plaque early, start keeping it from getting unstable, and suddenly you don't need aspirin. And the biggest problem with aspirin is not its benefit, but its detriment. Okay? And if we had all the benefit of aspirin and no detriment, which is what the holy grail of many companies are with regards to better antiplatelet agents, I think that then we would find that inhibiting the coagulation system is going to be a key part of this. We just need a much better drug than aspirin. And it just has too many side effects that are underappreciated. And what makes it more underappreciated than anything else is its availability. I think, in summary, what's the art of this? I think the art of this is communication. It's figuring out who's at risk. It's assessing their risk in a rational way and making the individual whose risk you're assessing a part of that. Understanding their fears and trepidations both about assessing their risk and treating their risk ahead of time. Getting them to understand what you understand about the knowledge in a understandable way using analogies or whatever else you need to do to communicate. Communicating trial data to individuals goes right over their head, okay, and isn't effective. Communicating what your impression is and what a likeness is and what goes on with things, I think, is a much, much better way to do this, okay? People will respect your opinion when you're prescribing these drugs. They want your opinion. Some people want your not only opinion but direction. And if that's what they want and that's the kind of patient population you have, that's fine. That was the old medicine. I think a lot more people now, they want to be a part of this, and we need to embrace that. But the way to be a part of this is to understand the data, to have very good understanding of what you apply. You don't understand the whole field. You need to understand what you're using to treat with and what your limitations are. And then saying, this is how I understand it. If you have a different opinion, here's who you need to go see to talk about that opinion. Okay, and I think those are the keys. And that's how I like to approach these patients.
Yeah, Rod Califf always says that the therapeutic decision should be based on science, and the art of medicine is how you interact with the patient.
Yeah.
And so let me ask you, you said early on in the last few seconds that we have here, you think of diabetes, I think most cardiologists think of diabetes as a cardiovascular disease. Give me your perspective on the pre-diabetic patient. I think metabolic syndrome is still debated a little bit. I think we all recognize that something is happening at that early stage. And tell us your approach to that type of patient, someone who doesn't have frank diabetes yet.
So, yes, remember, we define diabetes as a number, okay? That number, 126, is 7 millimole. It actually is a guideline number in the rest of the world. It doesn't make sense here. It makes sense in the rest of the world. It's a nice round number, simple to remember, okay? Back before you were an attending or a fellow, the number was 140, okay, back when I was a student, and then people keep ratcheting it down. I think the metabolic syndrome is simply the next ratcheting down. This is a continuum. You don't develop diabetes. You don't have diabetes. This sensitization to environmental risk factors is a continuum in our society. And that continuum is based on having cholesterol, which is more sticky, and that's a reaction to central fat, I think, more than anything else, and having an endothelium which can't defend itself anymore, which is a combination of both some sort of issue with handling of glucose, okay, a big issue with regards to how it's affected by blood pressure, and a big issue also of how it handles the assault by lipids, which were designed to go to specific cells for a reason so that they can make the machinery we need, and unfortunately go into the wrong place because of the damage they have. So that's how I would address that. I think it's all a continuum. I think the metabolic syndrome is simply a form of diabetes which is not yet come. I think the risk associated with it approaches diabetes but doesn't quite make diabetes, okay? But how many people do we see that get their diagnosis of diabetes after their first MI, and then they have diffuse disease, and they've had this all along?
Yeah, so it sounds like we've got a lot of work still left to do.
Absolutely.
Well, thank you very much, Mike. It was a very, very interesting talk on a very high-risk patient population. My guest faculty today has been Michael Blasing, one of my colleagues here at Duke. Mike, thanks again for joining us.
Thank you, Sunil.
Until next time, then, from all of us here at Duke, this is Sunil Rao saying thanks for joining us and take care.